Morning, all my friends online. We are back for our Monday morning chat about leadership. I'm truly honored today to be joined by Dr. Raju. He was my former boss over at New York City Health and Hospital. I have great and fond memories of working together, not only going to the board meetings, but more importantly on the Vision 2020, where we wanted to work on changing the way we delivered ambulatory care in New York City to 4.5 million patient visits per year. And I think, together as a large team under his leadership, we have done some phenomenal work. And I know that they're still carrying that forward today in getting better every day, through DISRIP, through PCMH, through Health Home, and many other ways. So, Dr. Raju, welcome here today. I know you're doing phenomenal work today at Northwell, and we have a very important topic to talk about in a little bit when we talk about health equity and social equities in healthcare itself. But take us down the road a little bit of how you, chose from being a doctor to wanting to be in leadership and the impact you wanted to make as a leader on your peers, and then how you get into a more of an executive role, a more strategic role. So again, welcome for joining us today, and look forward to a great conversation.
Great, Walter. Thank you very much. Cherish this opportunity to connect with you again and talk to you. So I have been a very uh, hardworking practitioner in mostly academic fields. So I did all the things you're supposed to do, like operate on patients, teach people, and everything we did. There was this change which came around somewhere around in 2000 happened to be a patient of mine whom I operated on. Subsequently she's supposed to show up for chemotherapy, and so in healthcare we use the word rather saying that these are what we call non-compliant patients. That simply means that these people treated or they don't care about themselves to be taken care of, which I did not buy that. Develop a close interaction with this woman who happens to be a woman who has been in this country over 30 years, but she was undocumented. A lot of work, and she put her children to college and school, and she's been one of the upstanding queens, which I thought it was very unlikely. When I did a little bit deeper dig into that, I found out that she was under the enormous pressure to vacate her apartment because they were able to. Somebody was offering more money to be in their apartment. Basically, it said, "Look, I want to get rid of you, and if you're going to walk out, I'm come in, and you can't go to the police because you are an undocumented immigrant. The minute you put you in a bus and send you back to where you come from, right?" So she has got the I continue with my cancer therapy and get rid of cancer, maybe get and become homeless, or I should stay in my home, not worry and able to be not hopeless. So these are some of the areas we as a physician don't completely understand the patient. So we basically say, "Hey, I told you it. That's it's so simple. What looks simple to us is not very simple to them." Lady could have the best of treatment, with the best of chemotherapy, the best of pharmaceuticals, the best of doctors, but our does not depend on what we do. Our outcome depends on the landlord who is threatening to. So I got very much interested in the social justice, in social equity, and that started the journey through New York City Health and Hospitals, and then subsequently Cook, and then back to New York City Health and Hospitals. During the journey, I a very ardent spokesperson for health equity in this country, because I believe that you cannot have health equity in this country without social equity, and there is no quality equity. So those are some of the dictums you live by, and if you really want social equity in this country, you need to have social justice, and need to have an economic So elevate people in the lower strata of poverty and being not able to have any reason is because not because it's available to them, but they don't have the access to transportation to go to the doctor's office. They don't live in the area of food desert where they don't have money to buy the good food because cheap junk food is cheaper than buying good food. The areas what we call as a social determinants of health, and I got involved in this at the time. People were just kind of confused. They said, "Why are you even telling me this?" I just treated a disease, but I said, "No, you cannot just take care of a disease. You have to take care of the patient. Every disease there is a patient, and we need to understand that and deal with that because the social issues are so different." And then we came out with this great article. Only 20% of the outcomes in a chronic healthcare, the $3 trillion healthcare, basically address only 20. The 80% is non-clinical. The 40%, the 80% is directly related to the health literacy of the person. In healthcare for many years, patient education with literacy. Literacy is very different from, we spend a lot of money. We have educators walking around the hospital systems. We print all the brochures. In New York City Health and Hospital is like 25 different languages. But that is not important. It's the other part of it. And the other 40% is socioeconomic conditions in which they live. If they happen to a development or a NYCHA building, a public house, and their asthma infestation, their apartment, you can give them the best of medication for asthma in the emergency, get rid of that infestation of rodent. It's not going to get better. But we are willing in health many times as you want with asthma attacks to the emergency department. Each probably costs like $2. We will not pay for $20 of extermination fee to get rid of the underlying cost of it. Areas which I got very much interested, and I pursued the journey for the last 20 years on that. In somewhere around 2016, social determinants suddenly got fired. So I have been talking all around the country about social determinants, how to create a health equity of field, and that kind of created a big headwinds on the people to say, okay, now we have to treat not only the patient, also treat the circumstances, social conditions they live in. So we need to have the person, we also treat the person around it. So much of creating that, how do you address the social determinants? So there are some of the examples we did. So the app is in your cell phone. Because one thing everybody has right now is your cell phones. Whether you're homeless, you have a cell phone. When you're poor, you have a cell phone. So everybody has some kind of cell phone. So we created this app which, when you receive an information, the person who puts on the information, like healthcare system, insurance company, don't have to change anything. But the person who receives information find out, oh God, I don't understand that. You click a button, it goes to the next lower level. I'm reading this in the 5th grade literacy. Suddenly I don't understand. I hit the push of a button. And also, of course, you can get it in the language of your choice. And most important, you can also choose a mode of your learning. Because as we know, some of us are audible learners, some of us read a piece of document. So the same message could be into your smartphone, either through as a video or as an audio or as a listening. We used that extensively during the COVID because we really wanted to reach the people low literacy level and don't speak English as a main language. We were able to really make people understand what we want. How to wear a mask, how do you wash your hands, how do you practice social distancing means, because unfortunately most of the instructions over the television, either by the president or the governor or the mayor of various cities, needed some kind of English language proficiency to understand, or you need to at least level education understand. So it didn't really need reach people. This app was extremely helpful into that. That's one area. The second area we did was we have a medical risk score, because you have medical risk score. Doctor, all your chest pain, your risk score depends on your family history of chest pain, you're obese, you're diabetic, you smoke cigarettes, all those things, what we call risk factors. The same way we created a social risk patient. And we were able to show by addressing some of the social risk factors, we were able to outcomes without altering the medication. Because for many years, when the patients, not because of the medications we give, is because they're not able to get access to healthy. What we do initially is we increase the medications, or we put them on more medicine. So we have been social issues with more medications. That is why we have one of the most quality pharma. We take more medicine than anybody else in the world, because every social issue we give a medication.
Yeah.
And that's what we deal with. We deal in medications, which has been very good. Money is a huge pharmaceutical industry, and there is a lot of things which come with it. But sure, by getting the social risk factors score, they have a questionnaire. Based on that, there is an AI in the background which risk to 10. And in Northwell, we chose after 6. If you go beyond 6, which is high, you have automatically in the background, you get referred to a based or a government-based, social agency. In other words, that's called now is a resource guide. It basically says, okay, Ram Raju has a homeless issue. Okay, I'm referring you to a homeless agency in my zip code or near my zip code. So they send me an email and or a text message through my iPhone and say, hey, I got referred. They deal with the problem. They put that back into the electronic medical record that the proper housing, the risk score drops. Then we are able to show by scientifically that their hemoglobin now is much better because we took care of that particular issue. So we are able to assist for a large number of patients where we are able to risk classify them, appropriate social service agency. Again, it doesn't require the doctors to do anything except just to press a button. Risk matter automatically. Everything happens in the background. The agency calls you and then bring you back into the agency. And there is a lot of things. It could be government agency. It could be example for food insecurity. We worked with an agency. If God's love will deliver, they deliver medically tailored food. So when we started giving medically tailored food, the hemoglobin A1C level started getting better, even though the medication remain the same. We are asking people is we are telling the doctors, please don't reflexively increase the medicine in 4 months or 5 months. I will address some of the social issues, and you will see a definite improvement in there, because 80% of your outcomes are due to non. Those are some of the areas which I want to really talk to you and your listeners today.
So I thank you for the outline, and I think that going back to the work that we started back in the 2015-16 about the vision, it's behavior, right? And we spend so much money on clinically treating people, but not understanding the true behavior that goes into being a good patient, an educated patient. And we tend to glance over that. Interesting enough, my work that I do a lot with working with emerging leaders is that people go from technical skills to becoming leaders, but that transition is rather large, right? And a lot of it is behavior based. They don't take the time to learn the right skills, knowledge, and abilities to be a highly effective leader. Same thing is with patients, right? We give them the medicine, we give them the appointments, but if there's no follow up, then your clinical outcomes are not there to match. So I think that we really have to continue. We need to continue to work on both sides of the equation, both with at the patient level, and working on their behavioral aspect of why they're not following up, and how can we remove those barriers to give them the care where they live, right, and bring more to them, because it is always less expensive to do that than having them come to the emergency department. But I think leaders at the same time also need to spend more time understanding on what the real solution is, right? It's not more, more regular medicine. It's more about what is the behavior driven behind
Yes.
the decision making, and that's how we really can elevate our performance. Now, the question is, of course, we have had Health Home, we have had PCMH, we have had many other social, programs, including DISRIP, which was really the last big infusion of big dollars. What are the results? Are you seeing now that obviously with Northwell, you have a dedicated office with a big voice like yours, with someone who is very prominent, that drives this issue. Have you seen the results that you anticipate? In other words, all the time and effort that is gone, are we starting to see a shift in how the clinical outcomes of patients who were otherwise forgotten or lost in the system?
Sure. So just to be for what I just I worked in Northwell. I just want to make that clear. So going back to you make an important point, which is which is like water, like because you always been a right of the technology leader, or you are a healthcare leader, or you are what you need to understand behavior who uses your product. That is healthcare, or is it your computer? What are certain models of the cars are more popular? Why certain models of computer are more popular? Why with the ease of use and the ability to understand that, and less on all those things, right? So in healthcare, if you go to that, you want a better experience. You don't want this confusing intertwining road of navigating the maze we call health, shunted from place to place. Oh, did you go and see this doctor here? Get registered and go to the clerk and give your insurance form. We need to call an insurance company. So all those things is really extremely frustrating, confusing, and especially when you are sick, it is frightening. So what we have done for many years with either the districts programs we had, we basically gave more access to people. Right? We said, okay, I'm going to open my offices from. I don't close my office on till 9:00 at night. I'm going to open my offices on Saturdays, right? I am going to have a PCMH, which is going to take care of, you don't see me, you can actually see a part of it. So there's always availability. But then we said, the best access to the people. But we need to know where access. That is the issue. We never really kind of got that in the. If you something, can you come and get it for you? That is a bigger problem we had. So access because of other reasons. One, language, or they don't have the transportation, or they live in, or they are LGBTQ. They feel like they are being ostracized, or they don't worried about the immigration status may come out as a part of it. So you may get the best of access, can't get that. So that is what we changed over a period of time, looking and spending more money on making more access available. Let's also help what we need to do that. So that is the change in the mindset came out in the last 10 years. So quality is good, access is good, but I also have to. So what do you need to, or to access what I'm giving it to you? So that is the point. Look into that. And that is served with any leadership in any organization. Technology, or is it political, or is it social, or is it, know your audience, know your people who use your system, and see what you can do for them. They also have to know what they get out of it. So I always say, we keep asking them, what is matter with you? We should be asking at the end of the day. That is the question. What matters to you at the end of the day? So if you ask it in healthcare or any other leadership, you will get a much better understanding of the patients. If you want to solve a problem, solving a problem may matter to you, but they may not be a big deal for me. I lived with it all my life. It's not something new, but I want this more important to me. And we don't engage in the conversation. We basically say, hey, I know what is wrong and I'm going to give it to you, right? And then once I give it to you, then the problem always is, Walter, is everything in healthcare is we as a providers, but we never measure how well they got difference.
Yeah.
It's not how well we do, how well they got. If you start focus, then you will get a better healthcare delivery system. You have a better health equity through social equity, the future of the leaders. So understanding the social behavior, understanding what matters to them, and make sure that what you give, they're able to access or get whatever need to be done. So that is my three as any leader and any industry to follow.
Do you, so thank you for that. Do you think that people are talking about this enough? That is this a topic that is that we need to uh, put on the top of the agenda after safety, of course, uh, because I'm not so sure that we are talking about this enough. And I'll give you another example, very interesting. I just came back from Europe, and my mother, who had progressive dementia, and opted to be euthanized, and we went through this whole 5 month long application process, and we can't even talk about it in this country. But I have to tell you that, listen, I didn't want to lose my mom at 87 years old, but she had a dignified death. Right? It's again
Yes.
one of these issues that why
Yes.
don't we talk about this? And I think that we don't talk about that topic or your topic often enough. What can we do about that?
They're not. But unfortunately, what happens is when you select leaders, leaders emerge, but in the healthcare field, which is tightly controlled, leaders are being selected. The board of trustees are selected by somebody else. There is no way to measure the social leadership to direction. So they look at your experience, your education, and whatever. Well, you ran a system, but all about how well we did, how well you did, and how well they got. I could have probably done 50 different projects. All of them I consider, but the question would be, did it really make a difference in the neighborhood? So for that, you should ask another person, right? So there is no way for somebody to make a resume and the CV. There's no way for the interviewing team to ask. So what I believe we need to do to select leadership is we need to understand the context of the leadership. The leadership may be brilliant in finance, or brilliant in technology, brilliant in everything, or education, brilliant in doctor, but don't understand the social behavior, or they don't understand what needs to be done. Brilliance is all gone to waste, because they can produce great programs and won't be people enjoying it because they don't understand completely what happened with that. So we in the healthcare delivery system is a long way to go. We need to understand, selecting leaders, I want to make sure this is a people leader, right? I do great, wonderful, educationally, operationally, or experience-wise. Is he a person who can interact with the community, learn from the community, try to solve them with the community, not with your team, right? Because it's, you have to get out of your hospitals. You have to get to the hospital. Hospital will not have any more kind of goes into the community. So you understand whom you're serving. You unclick what doesn't click, and do that. And one last thing I want to do is experiments carefully, because healthcare is the only industry in the world use our own metrics, and we evaluate them, we collect them, we evaluate them, and my question is, does it even make a difference? I said, okay, I gave, there are 100 patients came in there, and I really treated 80% of them got the treatment. 200 people couldn't get it. What about 300 people who waited in the emergency department? We're not calculating them, right? So we said, 100 people came emergency department. We all see they are. But what about 300 people who left before you can get to 100 people? So our measurement system is flawed. It's not outcome based. It's very process oriented. First, take a look at that and then do it the right way. I think the leadership to understand what they're doing. It is, again, as I said, is not measure how well we do. We got to measure how well they got. So that is a way of looking at leadership.
So yeah, thank you for that. And we're almost at the end of the show. We could have talked for another hour probably about this topic, and maybe we have to come back and we'll have a follow-up chat. But listen, I really think that you're spot on, right? Is that we need to make sure that we look at the behavioral part of both leadership as well as the behavior part of the patient. And when we talk about going on the Gamba, go to where the work is done, but not only in the hospital. We need to go to where the patient is and meet the patient's need under their circumstance, understand their language, understand what their needs are. And it is not, the pressure you always feel in healthcare is about, meeting the bottom line. And I spent a little bit of time in the for-profit world, which I, by the way, did not care for all that much, because you can be great 3 months of 3/4 out of the year, and then you have to be a smart to everybody because you have to meet the street expectation for the fourth quarter. Again, I think that the work that you have done, you're doing today, I think that the words that we want to get out to the leaders of today as well, especially those emerging leaders, it's not just about the technical skills of finance or IT. We have to make sure that we understand that our behaviors drive performance. It is our behaviors that create new normals in order to get a higher level of performance. And it's the same thing for the patient. We need to make sure that the patients are met in their circumstances, not as a cookie cutter approach, but really understanding on how we can help them be compliant. And that is not, there's not one way of doing that. Dr. Raju, it has been a true pleasure, as always, to connect and hear your voice. I hope that the audience takes away something that is meaningful from this. This will be posted obviously on LinkedIn and Facebook and YouTube, and I will share with the teams around. Next week, we're going to pick it up with Michelle Figueroa. Maybe you might remember her too. She's currently a CFO, and we're going to talk about her journey and how she became a chief financial officer and what kind of insights she can provide to other folks. And we'll continue it on. Dr. Raju, I look forward to having a follow-up conversation with you sometime in the future. Again, thank you for all the work that you do, and know that you're making a difference in patient outcomes.
Thank you, Walter. It's a pleasure, really. Thank you.
Thank you. Talk to you soon, sir.